So today we'll be having a very interesting and important subject. Probably this is something the basic in critical care, the arterial blood gas analysis. And I know you are one of the instrumental teacher in teaching the students arterial blood gas analysis. So most of our students will be benefited from you, sir.
Thank you. Let's hope so.
Yeah, definitely, definitely.
Welcome, Dr. Ghosh.
Hi, Dr. Akhilesh. How are you?
Hi, I'm fine. How about you? I hope
Good.
doing well. You are doing well.
Yes, yes. All is-
Health-wise, lot of viral infections.
No, it doesn't. It usually doesn't. These viral infections, they do not affect these people who are born in villages, I think it's a disease of the city people.
Yes.
Yes.
This is my
Yeah.
feeling.
Yeah,
I
absolutely.
never had COVID. My son had, my wife had.
Okay.
I never had any symptoms, but I was
My
actually
God.
involved in COVID care.
Okay.
Okay.
God's grace.
That's good to hear from you actually.
Yeah.
So, because most of the intensivists they are being affected during the
Yeah.
COVID.
Mm.
There are very few who
God's
actually
grace.
got spared.
Yeah.
But have you checked your antibody levels?
It must be elevated now. I have been vaccinated thrice.
Okay.
Plus, I don't know. A subclinical infection must have happened. I just cannot deny it.
Right.
Yes.
So we have 30 our participant, or I can say the students and fellows, co-colleagues who have joined till now. We are expecting more. So by the time I will start with the introduction. So I think many of them will be joining. So can we start with your
Yes,
permission?
please, sir. Please.
Yeah, I think we can.
Thank you. So I welcome you all. I am Dr. Gunadhar from Apollo Hospital, Navi Mumbai, Senior Critical Care Medicine Consultant. And today we have our 29th Apollo Mumbai Critical Care Learning Network, which will be very interesting topic, and it is one of the basic topic I can say for any of the critical care specialists, particularly for the students, the arterial blood gas analysis. And today we have a wonderful speaker with us, Dr. Supradeep. Dr. Supradeep Ghosh is in charge, head of the department, Fortis Hospital, Faridabad, and a lot of time I have heard of teaching this subject very enthusiastically, and that's why I have invited him here to our forum. And welcome, Dr. Supradeep Ghosh.
Thank you.
And with
And
us,
that
my
too, Stewarts principle. Yeah, we will be able to hear the Stewarts principle.
yes, Stewart's approach of acid-base interpretation, correct. And today with me, Dr. Akhilesh is my colleague, consultant critical care medicine. And we have also Dr. Swapnil, who is our junior consultant critical care medicine, and our DNB fellows, Dr. Ashwini. So any questions, I request all the delegates to please put up in the chat box so that at the end of the talk, we will be taking one of them one by one and we'll discuss, and any doubts or any kind of clarification they want, they can put it on the chat box so that it will be easier for us. So without wasting any time, I welcome you all to this 29th episode of Apollo Mumbai Critical Care Learning Network. And I request Dr. Ghosh to share his screen and to start the session.
Thank you, Dr. Gunadhar and Dr. Akhilesh and colleagues for giving me this opportunity. As we know, we shall be discussing on arterial blood gas analysis through Stewart approach. If we know that mostly there are three approaches for analyzing arterial blood gas. The first one is, of course, the very traditional and so-called physiological approach, or what we call Henderson-Hasselbalch approach, the most commonly used one. Then we have the approach which was provided to us by the famous Sigurd Anderson, or the base axis approach. And the third approach, is what we call the physico-chemical approach, which was provided by Peter Stewart in 1970s. Now, all the three approaches, they actually are almost similar in their respiratory component. They differ significantly in their approach regarding metabolic acid-based disorders. So we shall be discussing about the Stewart approach, but before we move on to Stewart approach, let us first try to understand why we need this approach. Why we should not be satisfied only with the traditional approach. And there are various reasons. I'm just trying to summarize a few points. First of all, the traditional approach is silent about mechanism of metabolic changes. Traditional approach tell us, though, if this is metabolic acidosis, this is metabolic alkalosis, this is high anion gap metabolic acid, but they fail to tell us why there is a metabolic changes, why the pH has changed to either decreased or increased. Secondly, in the traditional approach, it is assumed that hydrogen ion concentration is directly changing and being responsible for manipulating the pH of the solution. Whereas Stewart says that hydrogen ion concentration changes are actually a result of different other changes. So hydrogen ion concentration changes are secondary to other changes. And it is rational also. Look at the concentration of hydrogen ion in body temperature in the plasma. It is 40 nanomole per liter, 40 nanomole per liter. Look at the water concentration in the plasma. This is 55.3 mole per liter. How can hydrogen ion individually or independently change its concentration on its own? It's not possible. What is the concentration of sodium? 140 millimole per liter. Hydrogen ion concentration, 40 nanomole per liter. So it's very, very irrational to assume that hydrogen ion concentration in plasma is directly manipulated on its own. Thirdly, we all understand that the assumption that bicarbonate ion is independently determining the metabolic component of acid-base balance is absolutely irrational. We all know bicarbonate ion is in equilibrium with carbon dioxide. How can both components be regulated by the same bicarbonate ion, metabolic and respiratory component? So this is again an irrational presumption. This Henderson-Hasselbalch approach doesn't tell us anything other than PaCO2 and bicarbonate buffer bases. It fails to tell us anything about the phosphate and the albuminate, which are very important components. Finally, it fails to give the clinician magnitude of changes in the metabolic component. It can just tell this is a metabolic acidosis, this is a metabolic alkalosis, but it cannot tell us how much is the actual value of metabolic acidosis, how much is the change in metabolic acidosis from the thing. So we start assuming that, okay, bicarbonate is 14, so it's a severe metabolic acidosis because normal it is 24. But these are only assumption. Finally, let me tell you one more thing. All these calculations which we do for this compensation mechanism, delta anion gap, all these things, all these calculations are based on healthy volunteer data and data derived from animal experiments performed in 1940s and 50s. So in extreme critical circumstances, in critically ill patients, possibly many of these formulae, the Winter's formula and other formulae may not be valid. So we do not know whether they are still valid in our severely ill, critically ill patients. That's the reason we need to have an approach which is more scientifically based and which has got more solid rationale behind it. That's the reason the Canadian biophysicist Peter Stewart proposed this physical chemical approach in 1970s, and his paper came out in 1978. I have a copy of this paper. If you want to see, I can show you at the end of the things. So he stressed on three individual components: water, carbon dioxide, weak acids, and strong ions. So he said that these are the components which finally determines the pH and other things. So let's come to the Stewart approach directly. Before, my dear friends and colleagues, before we move on to Stewart approach, I want you to forget about the Henderson-Hasselbalch equation for the time being. Please do not try to correlate Henderson-Hasselbalch with the Stewart approach. Then you will not be able to understand the things. Secondly, I want you to forget about all these fear factors. There is nothing to fear. Just try to understand the Stewart concept is based on some few scientific criteria. It says there are only three independent determinants of pH. Okay. The first determinant is something called total CO2 content. Total CO2 content is nothing but a sum of carbon dioxide, H2CO3, and bicarbonate. But for all practical purposes, it is nothing but the carbon dioxide, the PaCO2. Okay. So first component which determines the pH independently is, of course, the respiratory component, that is total CO2. Second component, which is the most important component for metabolic acid-base disorders, it is called strong ion difference. Now, for understanding strong ion difference, we need to understand the strong ions are substances that are derived, that completely get dissociated in the water. So these are the ions which are derived from substances that are completely dissociated in the water. For example, sodium chloride. It is completely dissociated in water to sodium and chloride. And strong ion difference is the difference between the sum of all strong cations, that is sodium, potassium, calcium, and magnesium, and sum of all strong anions. These are mostly chloride and to some extent lactate. So this is the most important component. And third independent determinant is something called ATOT. ATOT is the sum of all weak acids in undissociated and dissociated form. So this include albumin and phosphate. Albumin and phosphate in their ionic dissociated or undissociated form, right? These are called ATOT. So if you can make it more simplified, so independent determinants of pH and acid-base disorders are PaCO2, differences between all strong cations and strong anions, that means all strong cations and strong anion, especially the sodium, potassium, and chloride. And finally, the ATOT, or especially the albumin and the phosphate. I hope this is clear. Now coming to some other terms, one term called apparent SID, another term is called effective SID. So forget about whatever is written in this slide. Just concentrate on the Gamblegram in the right side of the slide. If you see the Gamblegram, as per the principles of electroneutrality, all the positive cations must be equal to the negative anions. Okay. Now look at the Gamblegram. Follow my the arrow. In this column, we have all the positive cations that includes sodium plus potassium plus calcium plus magnesium. In the other side, in this column, we have predominantly chloride ion plus some unmeasured anion, some albumin, some phosphate, and some bicarbonate. Now, what is apparent SID? Apparent SID is the difference between sodium, that means this side, sodium plus potassium plus calcium plus magnesium minus the chloride. So it means all these additional things, including unmeasured anion plus albumin plus phosphate plus bicarbonate, these are actually constituting the apparent SID. What about effective SID? Effective SID is nothing but the phosphate, albuminate, and bicarbonate. So actually, these are the two things. Now, effective SID and apparent SID. And the difference between apparent SID and effective SID is what we call SIG or strong ion gap. Now, this strong ion gap, if you can understand from it, strong ion gap is nothing but the unmeasured anion. Okay, let's recollect it again. Sodium plus potassium plus calcium plus magnesium minus chloride. This is your apparent SID. Whereas effective SID is nothing but bicarbonate plus phosphate plus albuminate. And the difference between these two is nothing but our unmeasured anion, which is also known as strong ion gap or SIG. I hope it is clear. Now coming to we talked about the SID, strong ion difference. What happens if the strong ion difference is decreased? Now, first of all, how can strong ion difference be decreased? Either the sodium must decrease or chloride should increase. Do you agree? SID can decrease only if the chloride ion and sodium ion, they move closer together. Either because the sodium ion has decreased because of the water excess, or chloride ion has increased because of the chloride excess. Right? The other reason why the SID can decrease is because the unmeasured anion, that the lactate and beta hydroxybutyrate, they have increased in size or increased in amount. Okay. So let's, so if suppose we have an SID which has decreased, SID has decreased. What happens to SID? This column has decreased in size. To maintain the electroneutrality, what will happen? This will contract the buffer base, the bicarbonate and this anion, this side. This side will decrease. This will result in a decrease in bicarbonate. That's what we see. We see that if we have a decrease in the SID, it automatically gives rise to a decrease in the bicarbonate. And opposite occurs when there is an SID is increased. There the bicarbonate goes up. I hope it is clear. Otherwise, we can discuss it in later stage. What happens if the A tot is changed? A tot. What is what? This phosphate and albuminate. Suppose the A tot has increased in size. Suppose the albuminate has increased in size. Sodium is constant, chloride is constant. That what will happen? The A tot is increased in size, so it will push the bicarbonate further down, resulting in metabolic acidosis. So albumin is increased, leads to metabolic acidosis. Similarly, phosphate is increased, it leads to metabolic acidosis. Opposite occurs when the A tot decreases. That's the reason we get metabolic alkalosis when there is a low albumin in our critically ill patients. Okay? And how the pH changes? pH changes because of the SID distortion. The distortion of SID changes the dissociation equilibrium of the water plus carbon dioxide and albumin itself. This results in an imbalance between hydrogen ion and hydroxyl ion, resulting in a change in pH. When the hydrogen ion concentration is more than the hydroxyl ion concentration, we call it acidosis. When the hydrogen ion concentration is less than the hydroxyl ion concentration, we call it alkalosis. I hope it is not confusing. Now let's make it more simplified. Simplistically speaking, let's try to remember that there are only 4 independent variables which determine the metabolic acidosis and metabolic alkalosis. These are SID, PaCO2, albumin, and phosphate. If the SID increases, this produces alkalosis. If the PaCO2 decreases, it produces alkalosis. If the albuminate decreases, it produces metabolic alkalosis. If the phosphate decreases, it produces metabolic alkalosis. The opposite is true. If the SID goes below 38 milliequivalent per liter, that produces metabolic acidosis. If the bicarbonate goes above 42 millimeter mercury, produces respiratory acidosis. If the albumin goes more than 4.2 gram per liter, this produces acidosis, and phosphate more than 3 milligram per deciliter, this produces acidosis. Rest all are dependent variables. Whatever bicarbonate, pH, and bisexic, these are all dependent variables. So it's very simple, and this way we can actually classify our acidosis. So if we go for acidosis, let's take an ABG. If the ABG shows a pH of less than 7.38, according to Stewart, it can have only two reasons. Either it's a metabolic problem or a respiratory problem. If there is a respiratory problem, the PaCO2 should go more than 42 millimeter of mercury. If there is a metabolic problem, it can be either because there is a decrease in the SID or there is a non-volatile acid increase. That means either the albuminate is going up or the phosphate, it is absolutely the opposite. Albumin is going low and phosphate is going low. That will produce the problem. In contrast, the SID can decrease either because the sodium ion has decreased or the chloride ion has gone up. So these are the things which can produce metabolic acidosis and respiratory acidosis. In contrast, in case of alkalosis, it can again have either metabolic or a respiratory component. If the PaCO2 is low, it is metabolic respiratory alkalosis. If the metabolic alkalosis is there, either the SID is increased or the non-volatile uric acids are increased. I hope it is not confusing. Any comment from the students?
No, I think it is. It's not confusing. It's clear.
Yeah, it's very,
So-
very clear.
So,
Students can keep the questions in the chat box.
Mhm.
I think there are no questions. We can go ahead, and once the questions are there, we will definitely answer. When student has written confused a bit.
Mhm. Okay. So
so,
that is
so
a
what I request, Dr. Supradeep, just the main thing, the strong ion difference. Can you again suppose a little bit elaborate? So that is the center point of discussion in every Stewart's approach. So
yeah.
then they will be more clear. Strong ion
Yeah.
difference.
Yes.
The strong ion difference is, let's try to understand what is strong ion. Strong ions are the ions which are derived from substances which are completely dissociated in the water. These are the ions which can be mostly sodium, potassium, calcium, magnesium, and chloride. Okay, so these are completely dissociated in water, and they are the strong ions. Now, out of the strong ions, some are positive ions, which are the strong cations, and there are some ions which are negative ions, these are strong anions. The difference between the strong cations and strong anions is the strong ion difference. Now, for all practical purposes, if you allow me, the most strong ions are the sodium as cation and chloride as anion. Because potassium, calcium, and magnesium, these are very tightly regulated by the body. So what is changing actually is mostly the sodium and chloride. And if you can recall, the normal sodium value is around 140 and normal chloride value is around 100. So difference between sodium and chloride are the most important determinant of SID. So normal SID we can presume is around 40 or maybe around 38 milliequivalent per liter, sodium minus chloride. Now, if the SID decreases, SID comes closer, sodium and chloride, they come closer, the SID decreases, that produces acidosis as per the Stewart concept. So if there is a decrease in the sodium value or an increase in the chloride value, the sodium and chloride, they come closer together and SID decreases, that produces acidosis. This is what we see after giving sodium chloride infusion. the sodium and chloride in the plasma, they come closer together and they produce so-called hyperchloremic metabolic acidosis. In contrast, if there is the difference between sodium and chloride goes apart, so either because the sodium has increased because of the hypernatremia, or chloride has gone down because of loss of chloride, like after vomiting. You have multiple episodes of vomiting, the chloride is lost, the difference between sodium and chloride goes apart more than 40, maybe 50 or 60 milliequivalent per liter, that produces alkalosis. I hope now it is clear. The difference between sodium and chloride, when they come closer together, this produces metabolic acidosis. When the difference goes more than 40, maybe 50, because of hypernatremia or because of hypochloremia, this produces metabolic alkalosis. Okay? So this is the main and most important things about the SID.
There is question why bicarb is not strong ion.
Okay. Bicarbonate is not a strong ion because they are never completely dissociated in the water. Bicarbonate is attached with the CO2, producing H2CO3, or H2O on CO3. They produce a plethora of compounds, so they are never a completely dissociated. Sodium bicarbonate is completely dissociated because there is a sodium. But bicarbonate, hydrogen bicarbonate, H2CO3, is never completely dissociated to hydrogen ion and bicarbonate ion. So this is not a strong ion. Lactate in turn is a strong ion. But lactate, because of a very minuscule amount presence in the plasma, normally less than 1 millimole per liter, they can be actually avoided for the purpose of calculation. Okay.
Yes. So if I can just make a comment here, the SID is one of the important questions for most of the exams.
Yeah.
The examiner tend to ask, and it is the center point of discussion. So this concept is only in Stewarts approach, I think. So
Yes.
Anderson, Hasselbalch, and the traditional approach don't have this SID concept.
No. It doesn't give. So basically, SID is a very simplified concept. So there are, again, there are three important variables which independently determines the acid-base changes in the plasma, according to Stewart approach. Number one is what we call total CO2. The total CO2 includes bicarbonate also, PaCO2 plus bicarbonate plus H2CO3. But again, for all practical purposes, we can forget about H2CO3 and bicarbonate. So it is the most important determinant is the PaCO2. If the PaCO2 is low, we call it respiratory alkalosis. If the PaCO2 is more, it is what we call it respiratory. I mean the other way around. If the PaCO2 is less than 38, it is a respiratory alkalosis. If the PaCO2 is more than 42, it is respiratory acidosis, just like Henderson-Hasselbalch and just like Sigard and Russell. Only thing is that in Stewart approach, we don't calculate whether it is there is a second disorder or not. It is straight away PCO2 is less than 38, respiratory alkalosis. PCO2 is more than 42, respiratory acidosis. Whereas the metabolic component has got two reasons. Either there is a change in the SID. As I said, if the SID is lower than normal, it produces acidosis. If it is higher than normal, it produces alkalosis. Or it is because of non-volatile weak acid, what we call ATOT. Now again, all practical purposes, the most important determinant of ATOT is albuminate. Albumin is present in the largest amount. So if the albumin concentration is high, this produces what we call acidosis, what we call metabolic acidosis because of high albumin. In contrast, if the albumin is low, then it produces alkalosis. So this is the simplified Stewart concept. I hope it is clear, Dr. Gunadhar.
Yes,
Yes,
fabulous. Yeah, let's go ahead.
Absolutely.
Thank you. Thank you.
Now, simplistically, we don't have to do any calculation for Stewart approach. Absolutely nothing. You pick up the ABG, you see that pH is less than 7.38. You know that this is acidosis. Now you have to find out what is the result for acidosis. Now you look for the your ions, all your biochemistry values. If you find your patient's sodium is low, that you know that this is probably one of the reasons for acidosis. Or you find the chloride is high, this is another reason for producing metabolic acidosis. Or you find your albumin is high, this is also another cause of metabolic acidosis. If you find the phosphate is high, this is the cause of metabolic acidosis. These are the independent determinants. You don't have to do any calculation for this. But if you still want to do a calculation, there are different approaches for doing calculations. If you are so fond of doing calculations, because we are used to doing calculations for Henderson Hasselbalch, so we are very fond of doing calculation. So these, one of the calculations which are being provided is what you call the Frenkel-Stewart approach, where these are the complicated things. There are multiple calculations. So as I said, sodium ion concentration is a determinant of metabolic acidosis or alkalosis. If the sodium ion is high, it will produce metabolic alkalosis. If the sodium ion is low, it will produce metabolic acidosis. Okay, sodium ion jada hai. If the sodium ion is high, SID is white, and this produces metabolic alkalosis. If the sodium ion is low, SID is low because sodium and chloride is coming closer together. So this produces metabolic alkalosis. So we can just simplistically see the sodium ion. If the sodium ion is anything above or below 142 milliequivalent per liter, then we call it water excess or water deficit. If there is a water excess, that means sodium is low, it produces metabolic acidosis. If there is a water deficit, that is sodium is high, then it produces metabolic alkalosis. Now don't get confused again.
Yes, we can take the questions later.
Yeah.
Few
I'll
students
just
have.
clarify once, because I know this is a problem students face. Sodium ion disorders are actually disorders of water. Okay, so if there is a hypernatremia, it actually means water deficit. So water deficit will produce hypernatremia, resulting in metabolic alkalosis, whereas hyponatremia is actually water excess. The hyponatremia or water excess will produce low sodium, leading to low SID and metabolic acidosis. So that's the reason I'm telling a water excess and water deficit. Second component, according to this concept, is the chloride. Okay, now chloride needs to be corrected from the from the sodium value according to this formula. Whatever chloride corrected is equivalent to nothing but the chloride observed into sodium ion normal, that is 142 divided by sodium ion observed. So if the chloride corrected is anything changed from 102, if the chloride is high, what will happen? The sodium and chloride will come closer together. The SID will reduce, leading to metabolic acidosis. So if your corrected chloride is more than 102, that means there is a metabolic acidosis because of hyperchloremia. Similarly, if your corrected chloride is less than 102, that means there is a metabolic alkalosis because of hypochloremia, what we see frequently after frequent episodes of vomiting. Similarly, Frenkel and Leith has given a calculation for albumin as given in the formula. Albuminate is nothing but 0.28 into albumin in gram per liter, whereas phosphate is 0.6 into phosphate in milligram per deciliter. So these are the formulae which needs to be remembered if you are so fond of doing calculations. Otherwise, simplistically, you can go ahead with just sodium, chloride, and albumin. SID can be calculated from this formulae: bicarbonate plus albumin plus phosphate. As I said, this is the effective SID, not apparent SID. This is the effective SID. Whereas unmeasured anion also can be calculated from sodium plus potassium plus calcium plus magnesium, and this formula, which normal range is 8 plus minus 2. I hope it is clear. I'll go for some examples. I would like to take some questions, Dr. Pati, because I know this is confusing.
Yeah, there are questions
Before
in
I
the
go
chat
to,
box. Can I
before
take
I
these
go to.
questions? Yeah.
So as I can see, I hope it is clear now, students, why the bicarbonate is not a strong ion. I explained bicarbonate is not a
Yeah.
strong because they are never completely dissociated. In the
In
alkalosis side, albumin and phosphate are shown high for metabolic alkalosis. Okay, this is I agree with you. This is a mistake. Metabolic alkalosis is produced by low albumin and low phosphate. This is a mistake. This is, I completely agree with you, and I agree with Usha. She has rightly said that in this alkalosis slide, albumin and phosphate are shown high, whereas it should have been shown low. So metabolic alkalosis can be produced
Yeah,
only when the albumin is low or phosphate is low. Finally, the slide reflects albumin, if increased, causes alkalosis, which is contradictory. I do agree with you. I absolutely agree with you. These were some mistake because during making the slides, if the albumin is increased or phosphate is increased, they produce metabolic acidosis. If the albumin is decreased and phosphate is decreased, they produces independently metabolic alkalosis. I hope it is clarified. Yogendra. Okay, Usha, thank you. Thank you. So, students, for your understanding, these formulae are important. I'm not denying that, but for all practical purposes, we actually in the clinical practice, we don't have to go for formulae. We just have to see whether the sodium is high or sodium is low, chloride is high or chloride is low, albumin is high or albumin is low, CO2 is high or CO2 is low. That's it for Stewart approach. You can straight away say this. But if you still want to use the albumin formulae, these are the formula available. Now let's talk about some real patients. These are patients from my ICU. Okay, so let's take the first case scenario. 46-year-old male, chronic liver disease, admitted with variceal bleeding. So, this patient is really sick, really sick. But if you look at the ABG showed a pH of 7.4, PaCO2 of 39, bicarbonate of 24, and base excess of 0. So, my dear friends, what is your opinion from the Henderson and Hasselbalch approach? So, I just want a quick comment from one or two.
Normal.
Yeah. What do you think?
Normal.
Using your Henderson Hasselbalch, so for it looks normal, but can you believe normal? Okay, Rishikesh has answered normal, Santosh has answered normal, Usha has also answered normal. Yeah, it looks normal because sodium, the pH is normal, PCO2 is normal, bicarbonate is normal, base excess is normal. But can you believe a sick patient like this can have a normal acid-base, absolutely normal acid-base things? Not possible. Not possible. Now look at the now one way to solve this thing is we can actually go for calculate an anion gap. Sometimes we see that all pH, PCO2, bicarbonate, everything is normal, but anion gap is elevated. Let's calculate the anion gap. So this is the biochemistry. Sodium is 125, potassium is 5.2, chloride is 98, and you have okay. So can anyone calculate the anion gap for me? Sodium 125, potassium 5.2, chloride 98, and bicarbonate we know is 24. Can anyone do it for me, please?
23.
Yeah. So if we take potassium into consideration, it will be different. Let's not take potassium into consideration. Let's calculate sodium 125 plus minus chloride plus bicarbonate. That comes around 22, 3. Now we have to go for albumin correction. How do you correct the albumin? Yeah. Which albumin can be corrected by 0.25 into 4 minus 1.3. So this comes around 23. Again, that's not correct. Anyone can calculate it for me? 4 minus 1.3 into 6.75. Anybody? So this is also almost normal, looks normal. So even albumin is not going to help. Now let's apply the Stewart approach. What we can see directly from here, the sodium is low. Sodium is low. Sodium low means there is a metabolic acidosis. Look at the chloride. Chloride is almost normal. But if you go for the corrected chloride, maybe it will be little change. Look at the albumin. Albumin is 13 gram per liter, 1.3 gram per deciliter, which is low. So this produces metabolic alkalosis. Look at the phosphate. Phosphate is 0.9. Again, it is low. It produces metabolic alkalosis. So we have multiple disorders. Low sodium leading to metabolic acidosis, low albumin and low phosphate leading to metabolic alkalosis. These are actually counterbalancing each other and producing a apparently normal acid-base values. So this is how the Stewart is going to help. A sick patient, critically ill patient, can never have a normal acid base. So if you go purely by Henderson-Hasselbalch or by Sigurd-Anderson method, you will be missing these acid-base disorders, and this can easily be found out only by looking at the biochemistry. Low sodium, low albumin, and low phosphate, which are counterbalancing each other. Yeah. 30, albumin is written as 13. 13 is 13 gram per liter. So that means 1.3 gram per deciliter. I hope it is clear, Pratik. Yeah.
So this patient has multiple disorders.
Yes.
Metabolic acidosis and metabolic alkalosis.
And this can easily be, just by looking at the biochemistry, you can easily decipher the things. You don't have to go for any calculation. But if you still insist on some calculation, these are the calculated values. By following the Frankel and Lathe formula, we could find out that albuminate is 3.64, which is low. SID is 28.54, again low. And this SID is low because the sodium is low and chloride is slightly higher. This is the corrected chloride. I said the corrected chloride is the chloride, which is there, into the current bicarbonate, current sodium divided by, this is how you calculate the corrected chloride, and go for this corrected chloride is around 111, which is much more than the normal chloride of 102. So you have a SID which is low because of both low sodium and high chloride. Low sodium and high chloride, which is exactly counterbalanced by low albumin and low phosphate. Simple.
So the beauty of this Stewart's approach is actually whatever we cannot pick up by the traditional approach.
Yes.
By the Henderson-Hasselbalch or your traditional approach, is you can actually pick up these mixed disorders or triple disorders or double disorders by this applying this formula on the Stewart's approach.
Yeah, and actually, practically, you don't have to use the formula because nobody is going to ask you the formula. You can easily find out the problems by looking at the biochemistry. The sodium is low, the albumin is low, the phosphate is low. These are the directly responsible for producing acid-base abnormalities. So why do we need a formula? We don't need a formula.
So if I give weightage to two most important, electrolytes in the whole concept is sodium and chloride.
Correct.
That we need to understand.
Practically sodium, chloride, and albumin. That's it. Even phosphate is not required. We don't need calcium, magnesium, all these things. These are actually for more complicated things. But
Right.
simplistically, you just need sodium and chloride. If any patient has got a high sodium or low chloride, there is a metabolic alkalosis. Low sodium, high chloride, metabolic acidosis. Similarly, if there is a high albumin, metabolic acidosis, low albumin, metabolic alkalosis.
Correct.
Let's take one more example.
So if the sodium and chloride, they goes in the same direction, probably the changes what we can observe is
Counterbalanced. It will be counterbalanced.
counter.
If the sodium also goes down, sodium goes down. Sodium goes down means there is a tendency for metabolic acidosis. Chloride also goes down, there is a tendency for metabolic alkalosis. So this will actually counterbalance each other. But clinically, we hardly get this type of scenario. We hardly get a low sodium and low chloride both. But we usually get low sodium and high chloride. Let's see one more case scenario. So this is the complete Stewart, and this is this. So this patient had a low SID acidosis because of water excess plus high corrected chloride, exactly matched by the hypoalbuminic plus hypophosphatemic alkalosis. That's the reason you got all values normal, pH, PCO2, bicarbonate, everything was normal, because these were all derived values. These were all dependent values. So these were all found to be normal. Now coming to one more simple case, again, it's all my patients. 45-year-old male, ileal perforation, post-operative with multiple organ failure. Let's see the ABG. ABG showed a pH of 7.33, PaCO2 of 30, bicarbonate was 15, and base excess of -10. Here, even Sigurd-Andersen is picking up there is some problem. Sigurd-Andersen is telling us that base excess is -10, that this patient has got a metabolic acidosis. Now, can anyone of my friends can find out what is your take home from the Henderson-Hasselbalch equation? What do you think? The pH is 7.33, PCO2 is 30, and bicarbonate is 15. So what are we dealing with?
So it's a Santosh has written it is a metabolic acidosis. I think it's right. Looking at the ABG.
Okay. So, okay. Sorry. Santosh, I am happy that you have rightly said. So there is a more significant change in the bicarbonate. So primarily it's a metabolic acidosis. Now we have to do a calculation. Follow the Winter formula, 1.5 into bicarbonate plus 8. What should be the expected PCO2? Santosh ji, I have a calculator with me and I can say 1.5 into 15 plus 8. So that is 30.5. Santosh is right. So this patient has got a metabolic acidosis and appropriately compensated PCO2. Now, what is the type of metabolic acidosis, Santosh? Sodium is 117, chloride is 92, and bicarb is 15. So that means sodium minus chloride minus bicarbonate. That is around 10. And we have to correct it with 0.6, this albumin. 4 minus 0.6 into how much? So it is around 18. So corrected anion gap. So it's a high anion gap metabolic acidosis purely. Santosh ji, what do you think?
Yeah, he has replied on same high anion gap metabolic acidosis.
Yeah. So great. So it's a high anion gap metabolic acidosis. Let's see the Stewart. We do, but बहुत complicated नहीं लगता है आपको? We had to do so many calculations. You Winter's formula, whatever we need to correct it. That now let's apply the Stewart. Simple Stewart at the bedside. You don't have to go for any calculation. Look at the sodium. Sodium is 117, which is low, which is pretty low. So there is low sodium means there is a metabolic acidosis. Look at the chloride. Chloride is 92. We need to correct it. We'll correct it from the place. Look at the albumin. Albumin is only 6 gram per liter. That means 0.6 gram per deciliter. So which is significantly low. And this is a very common thing in critical care. Majority of our patients are hypoalbuminic. So this low albumin, as we know, low albumin will produce metabolic alkalosis. So there is directly we can say by just looking into the biochemistry, this patient has got metabolic acidosis because of low sodium and metabolic alkalosis because of the the low albumin and low phosphate also. At the same time, this patient has got a respiratory alkalosis because the PCO2 is low. Here, unlike the Henderson-Hasselbalch equation, where we don't find any respiratory alkalosis because we follow that Winter's formula, Stewarts says this patient has got 3 different acid-base disorder. PCO2 is low. This is respiratory alkalosis. Sodium is low. This is metabolic acidosis. And albumin is low. This is metabolic alkalosis. Just simply by looking into the parameters. No calculation, nothing. Now, if you still want to go for calculation, these are the calculated values for you. For the same patient, we have an albuminate of 1.68, which is low, alkalinizing, SID of 17.28, low, acidifying, water excess because of the low sodium, high chloride corrected. So these are the 2 things which is produce acidosis. Alkalinizing, albumin is low and phosphate is low. Unmeasured anion is high, so 18 milliequivalent per liter, so it's acidifying. So it's a mixed disorder. And final composite diagnosis is a both low SID and high urinary unmeasured anion acidosis, partially offset by hypoalbuminic metabolic alkalosis. So you can calculate using the Frankel and Leith formula. Okay. Any comment, my dear students?
No, I just request to share after this lecture in the chat box if all these formulas by you, so that they can just note down in one page.
No problem.
Yeah, or otherwise if the PowerPoint can also be shared.
Yeah.
It is feasible.
But I strongly discourage students for real practical purpose not to use this formula. Because the beauty of Stewart approach is not to use formula. This is the most beauty. Using formulae, again, we are trapped in the same Henderson-Hasselbalch problem. The beauty is you can simplistically find out the acid-base disorder by looking into the sodium, chloride, and albumin. That's it. Okay, I'll go for, we have time, then we can go for one more case.
Yeah.
So are there conditions where the sodium is normal, but there is still metabolic acidosis? Even chloride is normal.
Yeah. Sodium is normal, but chloride is high. It will produce metabolic acidosis.
If both sodium and chloride are normal, are there conditions?
Albumin
or phosphorus. Yeah.
Albumin is high or phosphate is high, it will produce metabolic acidosis.
And the second thing, what most of them are interested to know, whether it can differentiate between high anion gap metabolic acidosis versus normal anion gap.
So this concept of high anion gap and normal anion gap acidosis is only for Henderson and Hasselbalch.
So there is no such concept in Stewart's approach.
There is no such concept in Stewart, but you can have something called unmeasured anion or strong ion gap. As I explained initially, the apparent SID and effective SID, the difference between apparent SID and effective SID is nothing but practically the causes of high anion gap metabolic acidosis. So SIG is closely related to the causes of high anion gap metabolic acidosis, but we don't have any concept of high anion gap, normal anion gap, all these things. So we straight away just say there's a metabolic acidosis or metabolic alkalosis.
So whatever the approach they follow, like Henderson's, they have to quote that this is for the Henderson equation, this is for the Stewart's equation. But both the approaches should lead to the same concept, whether
Yes.
it is acidosis or alkalosis.
Yeah, ultimately we are interested whether there is acidosis or alkalosis or not. We are not interested in high anion gap, normal. This is the artificial calculation we have created.
And the causes will also remain the same.
Yeah, SIG causes will remain same. Okay, so let's see this 72-year-old female patient post cardiac arrest, hypoxic ischemic encephalopathy. pH is 7.55. PCO2 is 29, bicarbonate is 25.5, and base axis is +2. What do you think, students from Henderson-Hasselbalch? So pH is high, PCO2 is low. So there is a respiratory alkalosis, and this is probably an acute respiratory alkalosis. So apply your formulae and find out whether the bicarbonate is appropriate or not. Yeah. So bicarbonate looks appropriate. Okay. There is slight elevation of the bicarbonate. So this is according to the Henderson-Hasselbalch equation. It is purely respiratory alkalosis. Base axis is also +2. But this is very unusual for a patient of hypoxic brain damage not to have some metabolic component. It is just not possible. So look at the biochemistry. Sodium is 159. So according to Stewart, sodium 159 means sodium is high. The strong ion difference is a wide strong ion difference. So patient must have this metabolic alkalosis. But can you imagine having a patient with only hypoxic ischemic encephalopathy without involvement of other organs? It's not possible. So this is unusual that a patient can have only respiratory alkalosis. So from Stewart, we can easily say sodium jada hai, sodium is high, so there is a metabolic alkalosis. Chloride is high, there is a metabolic acidosis. Albumin is 0.9, so there is a metabolic alkalosis, and so on and so forth. If you want to calculate, so these are the formula applied. Again, I'm not very fond of calculation. अगर calculate ही करना था तो doctor थोड़ी बनना था. So you can easily find out these are the according to the Frankel and Lake formula. I'll share the formulae with you people if you insist. And finally, it is an alkalosis due to water deficit and hypoalbuminemia, which is offsetting the effect of high anion gap, high unmeasured anion acidosis. So this is how you can calculate the case. Okay, students. Yes, Santosh. Metabolic alkalosis is low water. Metabolic acidosis is low water, and metabolic acidosis is high water. Yeah, water excess. That's it from my side. Thank you very much. If you read this book, you will definitely find all these approaches. Otherwise, I'll share.
Fantastic, fantastic.
Yeah.
This book has all these formulae.
Yeah, tough. Back.
So there are one question like, do we apply this approach to change the treatment strategy when compared to the classic Henderson-Hasselbalch equation? Can it change your management plan?
Yes. Henderson-Hasselbalch, how it is going to change your management plan?
Like suppose they classify whether it is a normal anion gap, hyperchloremic acidosis, or
Suppose it's a normal anion. Suppose it is a normal anion gap acidosis. What are we going to do about it? Nothing. Practically nothing. Practically for the acidosis part, we are not going to do anything. We are trying to find out if there is a normal anion gap acidosis, then we try to find out urinary anion gap or potassium value and try to find out is there a type 1 disorder, type 1 renal tubular acidosis, type 2 renal tubular acidosis, or type 4 renal tubular acidosis. Or we try to find out whether there is a drug responsible. For example, type 2 renal tubular acidosis because of amphotericin B. So we try to remove the amphotericin B if it is possible. So we are not directly treating the acidosis or alkalosis. We are treating the cause behind the acidosis and alkalosis. It is true for us also. We are strong ion difference. If we can find out the metabolic acidosis is because of high chloride. So we'll try to reduce the sodium chloride component in fluid. We try to find out the metabolic alkalosis is because of low chloride. Then treat it with chloride containing fluid. And I'll tell you one more thing which Stewart can easily tell us. Now tell me one thing, what will happen to a healthy human being if he or she is infused with 2 liters of 5% dextrose? What will there be any acid-base changes? Student, you can reply. If a healthy volunteer is infused with 2 liters of 5% dextrose, what will happen to the acid base? Santosh answered metabolic acidosis. Santosh, can you explain how? Okay, here answered rightly. So there is this is a simplified things. If, yeah, Santosh, you can answer.
Yeah, he has rightly told it can cause hyponatremia because the free water get that dextrose get metabolized and it causes.
I hats off. Great, but I'll tell you more simplistic formula. Whenever you are infusing a patient with any IV fluid or any individual with IV fluid, you just need to see the strong ion content of that IV fluid. Even the IV fluid, like for example, if you give 0.9% saline, what is the strong ion difference of 0.9% saline? It is 0. So sodium minus chloride is 0. Sodium content of sodium chloride is 154 milliequivalent per liter. Chloride content is 154 milliequivalent per liter. So difference between these two is 0. Similarly, 5% dextrose has got a strong ion difference of 0 because sodium content is 0, chloride content is 0. So if you infuse any fluid which has a strong ion difference less than 24, this will produce metabolic acidosis. Or if you infuse any fluid which has an SID less than the bicarbonate of the patient, this will produce metabolic acidosis. In contrast, if you infuse any fluid which has an SID more than the bicarbonate of the patient, this will produce metabolic alkalosis. For example, I'll give an example. We have a patient who has a bicarbonate of 20. Okay, you infuse the patient with 2 liters of ringal lactate. What will happen? Ringal lactate has an SID of 27. Okay, so 27 is more than the bicarbonate of the patient. 2 liters of SID, 2 liters of ringal lactate infusion will produce metabolic alkalosis to this patient. But same ringal lactate, if you infuse to a patient who has got a bicarbonate baseline, for example, patient has a COPD. Baseline COPD patient has got a high bicarbonate. So patient has a COPD patient has a bicarbonate of say 36. I'm just giving an example. 36, you infuse this patient with 2 liters of ringal lactate. Ringal lactate has a SID of 27, which is less than 36. Now, this time, ringal lactate is going to produce metabolic acidosis to this patient. So, ringal lactate is going to reduce the bicarbonate content of the patient as per Henderson and Selberg. So, this is so simplistically, Stewart can tell us what will be the effect of a particular intravenous fluid on the patient.
Correct.
Let's see the SID of the solution. And SID of the solution will tell, and you know the bicarbonate of the patient, and it will tell you what will be the effect after a liter or 2 liters of fluid. That's the simplistically why sodium chloride is producing and causing the problem.
So this is definitely changing the practice because next time whenever we give the fluid, so we have to look at the SID rather than the electrolyte content of sodium and chloride.
Yeah.
This is a concept where actually we know whether the patient is going to be acidotic or patient is going to be alkalotic. Very important take-home message.
I'll tell one more example, Gunadhar, if you allow.
Sure, sir, please.
What will happen to a patient who has an artificial bladder, CA urinary bladder, and they form this artificial bladder, and this ureter is implanted in that bladder. That they form this from the ileal conduit, the bladder, the surgeons, and the ureter is implanted to that. Now, what will happen to the after what we call ureterosigmoidostomy or whatever? What will happen to the patient? What is the acid-base impact of this patient, and how you can explain it? Now, urine contains a lot of
These
chloride.
patients will have normal anion gap metabolic acidosis
And how?
because of the bicarb loss. Yes.
So I'll tell you a different concept. Let's see, normally we have a lot of chloride in the urine. This chloride doesn't get absorbed from the urinary bladder. True? Now, if you implant that bladder, that ureter in the sigmoid colon, what will happen? Whatever chloride is there in the urine, this will get reabsorbed from the sigmoid colon, producing transient hyperchloremia. Now we know the hyperchloremia produces low strong ion difference and metabolic acidosis. So this is another way of explaining the things from simplistically from Stewart. No bicarbonate, nothing.
So
It's so simple.
there is one question from Usha. So if you can again explain in only 2 or 3 lines, what is the importance of SID concept? Again, more than 24 and less than 24, just for their take home.
I'm ready to do it a number of times, no problem. So the SIG, I was talking about the SID. SID is the strong ion difference of a particular solution. If the strong ion difference of a particular solution is less than the bicarbonate of the patient, after infusion of that particular solution, it will produce metabolic acidosis. For example, a 0.9% saline has an SID of 0. Sodium minus chloride is 0. If you give 0.9% saline to any patient, it will produce metabolic acidosis, because this is always below the less than the bicarbonate of anybody. The bicarbonate can never be 0. In contrast, if you give SID of ringa lactate is 27. SID of ringa lactate is 27, which can be either more than the bicarbonate of a patient or less than the bicarbonate of the patient, depending upon the baseline bicarbonate of the patient. For example, for a healthy male, say for example, Dr. Gunadhar Pari, he has got a normal bicarbonate of 24. Now, if we give 2 liters of ringa lactate to my friend Gunadhar, since his baseline bicarbonate is 24, which is less than the SID of ringa lactate, it will produce metabolic alkalosis on him. In contrast, if the 2 liters of ringa lactate is given to a patient of COPD, whose baseline bicarbonate is 36 or maybe 35 or maybe 40, bicarbonate is high, that is more than the SID of the ringa lactate. You give ringa lactate 2 liters, it will produce metabolic acidosis. So this is how, I hope it is clear, Usha.
Fantastic. So if I can summarize in only the gist. So we have 3 approaches. One is the traditional approach, Henderson-Hasselbalch approach, and Stewarts approach. So in Henderson-Hasselbalch approach, we can either have metabolic acidosis, which can be high anion gap or normal anion gap. And in Stewarts approach, we just have one. We can determine whether the patient is acidotic or patient is having alkalemia. That is the simplest way to approach. And always, whenever you approach the patient with Stewarts approach, basically what we look at is the strong ion difference, SID. So you determine the SID, and as per the patient bicarbonate, if you're giving some fluid, then you determine whether that fluid is going to cause acidosis or alkalosis to that particular patient. If the SID is more than bicarbonate of the patient, then it is going to be cause alkalosis to that particular patient. If the SID is less than the bicarbonate of the patient, it is going to cause the acidosis for that particular patient. And so the bottom line is, in every approaches, the respiratory problems usually they don't vary. If I'm not wrong,
yes,
it is always acute respiratory or chronic respiratory problem. But only the metabolic problems are different approaches in different acid-base approach. That is what Dr. Ghosh actually described nicely. So I appreciate.
Thank you. I hope my students got some benefit out of this.
Yes.
Definitely,
Yeah.
definitely.
Students have written thank you, and really on behalf of Department of Critical Care Apollo Hospital, we thank you, Dr. Ghosh, for your valuable inputs on understanding the strong and difference, which is less understood. And students have definitely got benefit. Hope to see you more often than this, and students will be delighted
sure.
to see you again.
So,
And
can we extrapolate the lectures further to just to have some more interesting concept, Dr. Supradeep? If you can have more lectures on this in the next month or coming months for us.
You want me to talk about the Stewart again?
Just the extended version of this Stuart, how to like the fluid therapy, and I think you have a good recorded lecture on fluid therapy on many of the social networking platform. YouTube.
even hyponatremia is really less understood, so that can also be a
Talk
good.
about the fluid therapy.
Yeah. So one question is, can we please post a recorded video? Of course, we can post, and you can subscribe to our YouTube channels, Apollo Mumbai Critical Care Learning Network. We are uploading the videos slowly, so you can get all those recordings with the permission of our speaker there also, if you don't mind, of course.
I'm fine with that.
Thank you. So just subscribe to our channels. So hope with this we can wind up today's session.
Next week's session.
Yeah, next week's session will be on artificial intelligence on critical care by Dr. Srinivas Sambevadam. So hope to see you soon on the next Friday, 7:30. Sir, if you are available, I also share the link with you.
Thank you.
Thanks. Thank you.
So thank you. Thank you. Bye bye. Good night. Good night. Good night. Good night.